So I'm David Newey. I'm Deputy Chief Information Officer at the Royal Marsden, and I run the digital services team at the Marsden in support of the clinicians in terms of both their treatment of patients, but also with regards to clinical research studies that are undertaken in terms of curing cancer. Okay, so artificial intelligence is still a fairly embryonic technology, and at the moment we're seeing a lot of research projects that have been undertaken using artificial intelligence and looking at the boundaries and possibilities. At the moment, a lot of focus is being placed on areas such as radiology, reporting and analysis of images, because there is within the healthcare sector a significant shortfall of trained radiologists. Alongside that, there's also issues around the time it takes to detect disease, particularly with regards to radiology images. And so as a consequence, artificial intelligence is being used in order to look at both radiology images and also pathology slides to analyse visually for abnormalities in order to kind of triage those images and prioritise images within a clinician's work queue, such that high-risk patients can be flagged fairly quickly and fairly early on. So there's a lot of studies that are going on with regards to that. Our own Christina Meziou is working with Imperial College and looking at that particular issue, and is currently undertaking research studies. Alongside that, we're also in the process of implementing digital pathology solutions within the trust, again with the aim of being able to look at furthering those kind of studies. So in the first instance, certainly from our own trust point of view, we're looking very much at the diagnostic technologies that can be used to enhance detection rates. More broadly though, artificial intelligence is being used to look at clinical decision support, and particularly looking across longitudinal records at predictors for cancer and other diseases, and recommending earlier interventions in order to address that. So the key challenge that we've got there is having a complete data set for a longitudinal record for a patient. So in an ideal world, what we would have is a record from birth to death, which identifies a patient's various diseases and issues that they've had during their life, coupled with the results and coupled with medical interventions, whether that's surgical or medical, pharmaceutical, and then looking at the outcomes of those interventions to assess how successful they are. So if you couple that with potentially genomic data as well, then you can potentially move to a world in which you've got very much personalised medicine, which is based on a considerable body of evidence in terms of previous success factors and also predictors for deterioration, and be able to address those in real time. And then if you look at the potential of wearables, and we still again are in a very embryonic stage with regards to wearables, we can move from a situation whereby at the moment it's very much healthcare in the UK is very much driven from the clinician point of view in terms of arranging follow-up appointments and tests and so on and so forth. We could certainly move from that to a patient-led encounter with the clinician, where the patient will either trigger that interview or intervention, an appointment with a clinician based on either their own deterioration of health, which can be picked up through wearables or potentially through an app. So really, it's about monitoring patients remotely and how using artificial intelligence to identify when patients are potentially deteriorating. So going forward and looking really forward into the future, and again, it's very much underpinned by having the right level of technology in place across the entire health ecosystem, because you can't have gaps in that data. But I think looking forward, we will end up in a situation whereby medicine will be proactively interventional based on a body of evidence from previous patients and case studies, coupled with additional findings from the efficacy of pharmaceuticals and clinical research, and then augmented by additional data from wearables, and in order to make interventions both cost effective in terms of resource and clinician time, but also from a resource point of view, so not having to continually try different drugs, not having to waste drugs, not having to undertake tests that are needless. So there's a whole series of areas where artificial intelligence can bring considerable benefit to the NHS and to basically global population health. It's undoubtable that there is an issue just with regards to inequality in normal healthcare delivery. There's been a majority of studies, both in the US and in the UK, with regards to health inequality. And sort of recently, there was a study undertaken by the BMA, for example, around maternal deaths. I think this was up in Scotland, to do with the ratio of maternal deaths for white mothers versus black and Asian mothers. And it was determined that black mothers were 5 times more likely to succumb to maternal death. Asian mothers were 2 times more likely than white mothers to succumb to maternal death. So that is a snapshot of just some areas where health inequalities are prevalent. Now, it isn't a very polar issue. There are multiple factors that come into play. For example, if we look at the factors that come into play around vaccinations more recently with COVID, we can see that there are both cultural, there are ethnic disparities, there are social demographic disparities in terms of healthcare provision. And if we look at the various marginalised groups, what we can see is that certain demographic sectors within in the population are more likely to receive better care, predominantly white patients in the UK, predominantly male patients in the UK. So those kind of factors mean that we've already got within the data we collect, because of the number of interactions with healthcare. So the data that we collect and also the patient interactions that we have all form the basis of training data that we would use in an AI algorithm to determine effective treatment. So when we look at that, and we also look at other biases that can be introduced within artificial intelligence. So, for example, the bias of the teams that work on artificial intelligence, the more homogenous the group that works on an artificial intelligence algorithm, the more likely it is to be biased towards the demographic of that group that actually developed the algorithm. And that obviously in the UK, that means that white males generally will introduce unconscious bias within the development of their own algorithm. Equally, sampling bias, which again refers to what we were just talking about, is where the training data is skewed towards a particular demographic, which may not be applicable to a different demographic. So again, it's one of those aspects that if we're developing algorithms and introducing unconscious bias if the training data that we are using introduces sampling bias. And then we've also got other areas like temporal bias. So for example, when we devise an algorithm, what we are doing is we are basing it on the attitudes, the data, and also the science of the time. So in effect of 2022, anything that's written in 2022 will reflect what we know, what the societal composition is. And as time progresses, the shelf life, as it were, of that artificial intelligence algorithm will deteriorate because science will move on, and our knowledge and learning will move on. The society will change, disease and progression of disease and understanding of disease will change. And so as a consequence of that, any artificial intelligence routine that is developed now and hard baked into a medical type application will introduce bias that is current as of 2022. So the issue is making sure that actually we don't hard bake in attitudes and science that become 50 years old and are never renewed in terms of their understanding. I always like to say, one of the oldest bits of code that's currently in operation still was written in, I think it was about 1956 for the US Department of Defense, which is still being used today in live operational use. So the idea that a legacy piece of code that can be nearly 70 years old, that can still be used, it has a precedent. So it's one of those things that we have to guard against. And then other areas is where, for example, we try and generalize our cases using artificial intelligence to match the majority of the cases that will use that particular algorithm, but there will be edge cases and outliers which don't fit the model. And it's about making sure that those edge cases aren't discriminated against in terms of their use or their receipt of care as well. So there's those kind of areas that we have to address in terms of looking at bias in artificial intelligence. Okay, so we've got a very, very easy 4-step approach to trying to address this issue. The first one is raising awareness, particularly amongst underrepresented teams. So it's being aware that this type of bias exists and making sure that that's managed within teams that develop artificial intelligence. The second one is recruiting and training a diverse team. So it's not enough to be aware of the unconscious bias, but it's also important that we do something in terms of creating a more diverse and inclusive team. The next one is around providing challenge and oversight with regards to both training and testing of algorithms. So it is making sure that the governance bodies are in place to oversee that the correct principles are being applied in developing an artificial intelligence algorithm and that the training data is appropriate. And then the final one is ensuring that governance is in place in order to undertake regular reviews of the artificial intelligence algorithm. So it's in effect like having a certification date of saying that this algorithm is only valid from point A to point B, and after that particular date it's no longer valid and therefore should not be used. So it's about ensuring the currency of that AI algorithm.